Hello and welcome to the Principles of Intracranial Pressure 6-Minute Synapse series. In this session, external ventricular drains, measuring ICP via fluid-filled or external transducing, we will explore external ventricular drain concepts including hydrostatic pressure, how to properly level the drain, and common troubleshooting. My name is Jessica Ray and I'm a neuroscience nurse and clinical specialist at Natus. Most of you are probably used to the following setup. A catheter coming out of the patient's head, connected to a drain with a transducer, pictured in the middle, connected to the bedside monitor to see the actual ICP number and waveform. Did you know that this is a fluid-filled system? The transducer has a little microchip or sensor in there called a strain gauge. The pressure of the fluid in the tubing of the drainage system bends the sensor enough to make changes in the flow of the electricity. This is then translated into the ICP reading you see on the monitor. Because of this, there needs to be an active fluid column, meaning drainage from the ventricular catheter into the drainage system. No drainage, no pressure, no ICP reading. This is why it's important to make sure your catheter is patent and to notify the provider if occluded. Before we talk about leveling and setting the pressure level, it helps to have an understanding of how this works. CSF drainage happens because of hydrostatic pressure. Don't worry, we won't get too deep into physics. Hydrostatic pressure refers to the pressure exerted by a fluid at rest, at any set point within the fluid, due to the force of the fluid above it. We align the foramen of Monroe to the 0 point on the scale to make sure the fluid in the drain is in equilibrium before we can begin regulating it. Drainage occurs when the pressure inside the head makes pressure in the fluid column, here the CSF in the ventricular catheter, greater than the pressure or weight of the CSF in the drainage system. We regulate this drainage, and hence ICP, by raising the drip chamber to a certain height to create a pressure gradient or an uphill that the CSF has to overcome. When the system is open, CSF only drains when the interventricular pressure is higher than the set pressure level. There needs to be CSF in the ventricles, and the catheter needs to be patent for this to work. Therefore, this system may not be the best choice for slit ventricles with little CSF or situations where the catheter may be easily occluded. There are 3 main steps to zeroing and calibrating. We'll go over each in detail. Before anything else, the system must be properly leveled and zeroed at an external reference point in order to ensure accurate intracranial pressure readings and proper drainage. Adjust the drain so that the 0 reference point on the drain scale is in line with the referenced anatomical landmark, typically the tragus or external auditory meatus. See how everything lines up here? Confirm the landmark to be used and to make sure to use the same one each time for leveling. Now to set the pressure level. The pressure level, as specified by orders, determines drainage and thus regulates ICP. When the pressure in the head is greater than the set pressure level of the drip chamber, CSF will drain. Thanks, hydrostatic pressure. To set the pressure level, align drip chamber to ordered level on the scale. Here our level is 15 millimeters of mercury. Our patient, depicted on the right, has an ICP of 18 millimeters of mercury. CSF is draining as the pressure in the head, 18, is greater than the set pressure level of 15. Be sure to note which scale is to be used, centimeters of water or millimeters of mercury. As you can see, the values do not line up. Also note that the bedside monitor will display the ICP in millimeters of mercury. Zero transducer to atmospheric pressure at least once per shift, as there is a drift or loss of accuracy of measurement of 1 to 2 millimeters of mercury every 8 hours. It's also a good idea to re-zero if you are treating an elevated ICP to ensure that you have an accurate number. Refer to the manufacturer's guidelines and your hospital's policy with regards to how and when to zero. Why is leveling so important? It determines the accuracy of the ICP reading and drainage. Anytime your patient moves and/or anytime you need to transduce the ICP, you need to relevel. Incorrect leveling can affect ICP readings by up to almost 2 millimeters of mercury. This can mean the difference between getting treatment that's not needed or not receiving treatment that is needed. Proper leveling is important for drainage too. We don't want to drain too much or too little. If the transducer is well below the anatomical landmark, then there is risk of overdrainage, which can lead to serious complications such as collapsing of the ventricles and, in extreme cases, herniation. If it is above the landmark, this impedes drainage, and intracranial hypertension may go undetected. Inevitably, something happens where the waveform isn't the greatest or there's no drainage. Here are some hacks to get you through. Always check your institution's policies and orders before proceeding. No drainage? Check the ventricular catheter connection. Poor waveform? Check your scale. A waveform for an ICP of 5 will be hard to see if the scale is set to 100. Has the closed system been opened? A crani, otomy, or ectomy opens the closed space and dampens the waveform. Is there a subgaleal drain near the catheter? The draining fluid will alter the drainage pressure of CSF. As seen, the most common method to measure ICP is through an external transducer connected to an active fluid column via a catheter in the ventricle. To ensure the most accurate ICP reading, the transducer must be properly leveled to the foramen and Monroe, and the transducer is zeroed to atmospheric pressure at least once a shift. Make sure the system is draining and that you optimize your waveform for optimal ICP readings and patient monitoring. Here are the references for this presentation. Thank you for joining this presentation. If you have any comments or questions, please feel free to email me at jessica.ray@natus.com.